our session. So once again, after a short break, welcome back everyone to our Friday sessions. And we invite you to participate in the chat and help us out with our cases. Any comments and suggestions are most welcome. We have 12 cases today, so we'll quickly move on to our first case. So Geeta, over to you. Geeta, you there?
Yeah, I'm there. The screen is not visible, sir.
Now?
We are able to see the screen. Can you just slide it over? We are able to see, sir.
Okay.
So this is a 4-year-old male. Am I audible, sir?
Yeah, go ahead.
Yeah. So this was a 4-month-old male child who was referred to us from another hospital. So born term on day 5 had jaundice and like query seizures. They were not clear-cut seizures. And the child received vaccination around 4 months of age. Next day onwards, developed mild irritability and excessive cry. Initially, it was intermittent and it was consolable. By next 3 days, the cry was more of an unconsolable cry, and also there was associated with deviation of one eye inward and the other eye at the center. That is, disconjugate eye movements were there with excessive cry and abnormal movements. So this almost lasted for about 1 hour, and for which the child received multiple anti-seizure medications for the same. MRI was done on the next day of this episode. So here, like investigations wise, CSF analysis was done, and it showed protein of 72 and sugars of 40, and other cultures were negative. PCR was not seen. So here we want to know what can be the most etiology in this case.
So we have the MR on top. We have the diffusion variant sequences. Do not appreciate any abnormalities on the diffusion scans. No areas of restricted diffusion over there. Coming down to the T2-weighted axial sequences, you can appreciate that there are these multifocal hyperintensity. Yeah, these multifocal hyperintensities predominantly in the central regions of the brain, involving the basal ganglia asymmetrically, right more than left, the central white matter that is along the internal capsules, the bilateral thalami, and also possibly some areas of the peninsular white matter. More inferiorly, you can again appreciate, more superiorly, you can appreciate the involvement of the region of the cortothalamic group, the thalamus over there, the basal ganglia, and also the peninsular white matter on both sides. Coming down inferiorly, you can see that the mammary body is also slightly hyperintense. The midbrain is also slightly edematous. The cerebral peduncles and also the dorsal brainstem demonstrates these T2 hyperintense changes. There are no corresponding changes on the diffusion weighted scans. So predominantly T2 weighted abnormalities were there. On the SWI sequences, we could not appreciate any areas of abnormal blooming to suggest possible calcification or hemorrhage. And post-contrast study, there was no significant enhancement of the abnormal areas of the brain. Optic nerves also did not demonstrate any significant enhancement, and the visualized cervical cord, we could not appreciate any lesions or focal or long segment abnormalities in the spinal cord. So based on the MRI, we're thinking of infectious causes given the age of the child. Viral encephalitis was the most close differential which we thought on the imaging. Rhombencephalitis was thought of clinically. There was some brainstem involvement, so that's a possibility along the spectrum of infectious disease, also involving the supratentorial structures. Was not sure if antibody-related disorder is a possibility, but this was a child, though a slightly older age at 3 years old, where you can expect a more common age group. Again, it had similar abnormalities of which was seen in the index child, these multifocal areas of involvement, predominantly central regions, white and gray matter structures. But this is a 3-year-old and our child was a 4-month-old. So we wanted to know if it is common to expect antibody-related disorders at that age group, or to think of the infectious causes primarily presenting with our index child. So that's the imaging and the clinical part, and I'll open the case for the panelists and the other to comment upon.
I have 2 questions. First, do you have a follow-up? And the other question is, what about that vaccination? Was it kind of a routine vaccination as you do it in your country, or anything special?
Yeah, it was a routine vaccination. So it was DPT and PC, pneumococcal vaccination. And like the encephalopathy and all, like it was persistent only for 1-2 days, and then the child was fine. There were no any deficits. Follow-up was also child was active.
You think there is a relationship between this vaccination and the clinical situation, which started a few hours
But this was
later?
a second dose vaccination. It was not a first dose, like.
No, it doesn't matter. You can
Yeah.
have a reaction
Okay.
also following the 3rd vaccination.
Because post-vaccination only we have noticed all these, and so that's what we wanted to know, whether it is any post-vaccination inflammatory or immune response to that, or really any kind of infectious etiology.
Yeah, the only thing against infection was slightly uncommon was the absence of restricted diffusion. Usually there are some areas of restricted diffusion on the diffusion various sequences. Not always, but given the acuteness of the imaging pattern, after the clinical presentation, at least in the common infections, you would expect some areas of cytotoxic edema. So that was slightly be typical for only infection.
I have one comment. Problems following a vaccination within the first, say, 24 hours. This is a highly controversial topic. And there are, of course, two sides. One say this is nothing, this is just a fake, and others believe in this. I was educated by someone who was strictly against all complications. And I changed my mind when I had a similar situation in my own child following the 2nd vaccination. Of course, this was decades ago, and pertussis vaccination was not yet the best one, but I have experienced this kind of complication. I think it's not fake, it's real.
Can I make a few comments?
Yeah, please go ahead.
Yeah. So just if I'm getting it correct, so the only abnormality on the LP was the slightly raised protein, which in a way, if we're talking about infective process, it would be quite unusual to have. I mean, 6 cells is not that much, whereas the 72 protein is much more significantly increased. So the question is, this would put more towards kind of an inflammatory condition. I think we do need to sometimes be careful that some of the neurometabolic mitochondrial can mimic some of that, and they do have raised protein. But I think the fact that the child, and correct me if I'm wrong, has made a good improvement and is now essentially back to normal, is he? How long are we now follow up of this child?
We didn't have any other follow-up, like
when did this happen? When did he present?
He presented after the status and all. He presented about 5 days later, and he was
but
like,
what date was it? This week or a couple of months ago, or when was it?
Yeah, a month ago.
A month ago. And how has he been over the month?
No, we didn't have again the next follow-up. Only one follow-up we had. That is 5 days after this illness. He was fine.
Okay, so eating, drinking, there's no concerns from it. So I think we need to be careful that we're not missing anything like that. With them
for the follow-up again.
And the question is, with the 72 of protein, I mean, are we dealing with anything also peripheral? What was his neurological examination? Was his reflexes brisk? Were they normal, or could he have a mix, CNS and PNS? Or what did you feel from the examination?
The examination didn't reveal much, and we didn't get much handles from that.
Okay.
Yeah.
So I think the diagnosis is very open because, I mean, it does look like there's something happening. What's your upper limit for protein? 40?
Yeah, 40 to 70 is fine.
Okay, so this is only just raised, you feel?
Just
or-
raised, yeah.
Okay, okay. With regard to MOG, the youngest patient I've had was 6 months. That was actually MOG post-COVID. And then I had another patient that was 11 months. So we've seen a few under the age of 1. Normally at that age group, the MRI is much more florid. I don't know why, but what you see is that you get, you know, a very prominent, nearly like a leukodystrophy-like imaging, but asymmetrical. I feel a bit more florid to that, but interestingly, both of them quite acutely unwell initially, both got plex, and we've scanned them about 2 months after with pretty striking resolution of the imaging changing, suggesting that it may not even be technically demyelination, it may just be myelin edema. That is very impressive. So we can, I mean, if I've seen a 6 months old, I guess potentially you can see 4 months old. Generally for antibody-mediated diseases, you only start generating your antibody around the age of 3 months. So, you know, after 3 months, you have your maternal antibodies and only then. So it'd be very atypical to see an antibody-mediated disorder, even post-vaccination. That's why we don't see it. If you think the whole population get vaccinated at 8, 10, 12 weeks, and we don't see any antibody-mediated condition, because actually they don't really, at that age group, they're still kind of lingering with these maternal immunity before they start generating their own. So, you know, I think it would be atypical. Whether the vaccine has done anything else, possibly. So, you know, I think the question is, how do we feel? What's the most striking abnormality here? Do we feel the MRI? Was it the MRI? Is it the clinical presentation? And based on that, I probably would do nothing if the child continuing to develop well.
Thanks, Ken. Anything to add, Dr. Lokesh, or anyone else? Any specific questions?
No, nothing to add, Dr. Nihaal. Thank you. Thank you for all the inputs.
Got it. Right. Thanks.
Dr. Udani, can you,
Yeah, Dr. Nami, sorry. Yeah.
yeah, I mean, the one thing you think of, I mean, first of all, was this definitely seizures? And was there any fever?
There was no fever, sir. It was like they were describing the movements of some posturing and more of a
So you are
discontinuous
not
eye
seeing the
movement.
seizure, right? You're not
No,
seeing the
we
seizure.
have not seen the seizure.
Yeah, so the problem is the first thing which comes to mind, I mean, it was thought to be in the past, as somebody mentioned, vaccine encephalopathy, especially pertussis, and there was a lot of debate whether it existed or not. Then there were reports from Australia that many of those patients actually had sodium channelopathies. And the ones who had vaccine encephalopathy earlier on had actually sodium channelopathies like Dravet syndrome. Now, I don't think this MRI suggests that, because usually the Dravet syndrome, it doesn't look like a seizure-induced change either. So, but I think just to make a comment that this is first thing you think of is some sort of sodium channelopathy which comes after vaccination.
Mm.
And I agree that it's too
Yeah, I agree,
early to have
but Professor Udani, would you expect the phenotype to be much more, as in, if this is a child that present with Dravet following vaccination, they would have a vaccine encephalopathy, like at least the paper, I think they had 22 patients, they were very severe. So this sounds like the patient was quite well, had a query seizure,
No,
query
I
abnormal.
agree. I agree, but then sometimes you can get, I mean, the biggest point against it was the absence of fever. Usually you get seizures after vaccination, which were, you know, because of febrile seizures or whatever, but febrile seizures occurring so early in life are very often Dravet syndrome. And Dravet syndrome clearly does not show any changes. If it's not a very prolonged encephalopathy, does not show any development changes till much later, after the second year of life. The only thing is you can't explain the MRI. So I think it's probably a good point.
But the MRI at this age group, how much variability would one get with a myelination process with a possible insult or something? I mean, could this be borderline? Maybe a neuroradiologist can comment.
You mean for Dravet syndrome? Is that
No, for any, I mean, in a way, you know, there is some how much does the actual myelination at 4 months, affect what we're seeing, and could that could potentially, as we said, a Dravet syndrome can present like this because it affects the myelination or.
Yeah, but they're usually more symmetrical or
Exactly, yeah, but
more myelinitic edema rather than only musogenic type of edema. So,
okay.
right.
Watch and wait, I think. And has he
Yeah,
had an
he's
EEG or
improving.
not?
Yeah. Geeta?
Child had an EEG, maybe that's the only thing
The
missing.
child didn't had any EEG, ma'am.
So maybe worth doing. If it's really abnormal, then you may need to do something.
Yeah.
So we need to repeat the imaging for this child after about 2 months.
I'm not sure. I probably would go clinically because he's getting into an age that you may need to do general anesthesia. I would monitor him clinically a bit better. Not a bit better, but a bit more, see how he's doing. It's I don't know, because 2 months is a bit too. I mean, I don't have an objection. It's just that, particularly if you can get him maybe at the 6 months line or 7 months, that he can still do it without general anesthetic. But I think you need to be careful of treating the MRI and not the child in cases like this.
I support this view. I think the clinical context is very important if the child is perfectly well. There is no need for an urgent MRI follow-up.
Yeah. Or even you can even argue there's no need for an MRI follow-up.
Buddy.
Stop. Yeah. Yeah.
All right. Thanks, you. Thanks, Dr. Reddy.
Okay.
Again.
But EEG I would do.
Got it. Next case, Devangana.
Yes, sir. This is a 9-year-old male child with history of fever with rash. 7 days prior to admission. Fever was there for 5 days, and in between the child was afebrile for 2 days. And then the evening prior to the day of admission, he complained of headache. And the day of admission, the mother noticed that the child was not waking up from sleep. And when she went to wake him up, he was unresponsive with poor respiratory efforts. The child was immediately taken to a nearby hospital where the child was intubated, and the GCS was 3/15. There was no respiratory efforts, pupils were dilated, not reacting, and there was impaired brainstem reflexes. MRI was done outside before he had presented to us, and the MRI showed.
This is the one, Devangana?
Yes, sir.
Okay. So MRI showed bilateral cytotoxic edematous changes in the thalami, also involving the occipital lobes, the mesotemporal lobes, areas of the brainstem, the bilateral hippocampi over there, and also the left cerebellum, demonstrating these area of cytotoxic injury. Corresponding changes on the ADC sequences, and suspecting an ischemic process. Angio was done. I don't have the source images, only the MIP images, and you can appreciate that the vertebral vesicular artery system is abnormal. The left vertebral artery in particular is not visualized. The vesicular artery is not clearly visualized. They're sitting out the right vertebral artery. So going with ischemic changes in the posterior circulation territory with abnormalities of the vertebral vesicular artery system. I don't have a CT. If the CT was done, Devangana, so only MRI. And the question was any particular question on the MRI?
What could be the cause of such extensive injury? So vascular versus infective etiology.
He had high inflammatory markers and very hyperacute presentation. So whether that is triggered off a posterior circulation extensive thrombosis was the question.
Yeah, we don't have the source image, Dr. Lokesh, or the vessel wall images to check for inflammation. But there is a cutoff of the vertebral artery, so possibly of thrombosis.
Yeah.
And a secondary change of infection-related vascular injury. But I would need more the source images or the vessel wall images to better evaluate that. Any other comments on the possible cause by the panelists or the attendees?
Could this be something like ANE-like? You have involvement of both
Yeah, it looks like
alumni
ANE,
and the
yeah.
brain stem,
Yeah, I thought of that, but then again,
intratentorial.
yeah, again, I agree. The diffusion changes look like that, but then the vertebral arteries, you have some vascular abnormalities over there, and they kind of follow the posterior circulation. So
And even
unfortunately,
the extra additional lesion in the occipital lobe do not look like the annex. I don't know if it's more vascular than annex.
yeah, more vascular. Yeah.
Yeah, so it progressed very rapidly, and within 24 hours, we gave another 24 hours of stabilization to see if any changes in the brainstem reflexes. He didn't improve. CT scan showed further worsening with severe brainstem herniation. So family decided to withdraw the care. We couldn't ascertain. Probably this inflammatory, whatever the fever which was ongoing for a few days, must have given the inflammatory response.
Yeah. All right, move on to our next
Somebody
case.
has mentioned.
Sorry.
Somebody has mentioned ANEC. Somebody has mentioned in the chat ANEC with vascular injury possible.
Yeah, it's
But I
possible.
think there is no reason to bring in two pathologies.
Yeah.
Is there a need based on the imaging to bring?
Yeah, two pathologies, slightly atypical, going by common.
Unless there is a clear evidence on the imaging.
We don't have an SWI. We don't have a T1. So, and they're usually more target-oriented appearance of an ANEC than more the diffuse abnormalities of on the diffusion various sequences. So typically the ANEC type pattern.
Yeah, thank you.
Next case, Pituja.
Yes, sir. So we have a 7-year-old male child, developmentally normal child, who presented with headache and vomiting and loss of consciousness after he came back from school. So he was taken to nearby hospital where he was intubated for poor sensorium and bradycardia. And when he presented to us, we did an EEG that showed diffuse slowing and imaging was done. So we want to know the patterns of injury in this scans.
So what was the time frame? Within a day?
He had headache and vomiting 1 day prior, and this after 3 hours he was intubated, sir, and then he presented to us.
So the diffusion, we can appreciate extensive injury, predominantly involving the cerebral white matter, but also regions of the basal ganglia over there, the cortex, subcortical deep white matter, the corpus callosum, particularly the splenium of the corpus callosum, the optic tracts, optic chiasm, the cerebral peduncles, and on the ADC sequences, you can better appreciate the areas of cytotoxic confluent edema, predominant involvement of the subcortical deep white matter, also involving the splenium of the corpus callosum. The basal ganglia changes on the DWI do not show the reversal on ADC sequences. But again, you have predominant confluent white matter abnormalities, predominantly in the peripheral regions of the cerebral hemispheres on both sides. Corresponding flare edematous changes. Again, the white matter is slightly hyperintense. Also, the deep gray nuclei, that is the basal ganglia, demonstrate these edematous confluent changes. No hemorrhage or calcifications on the SWI sequences. And given that imaging findings, possibility of a toxic etiology was considered. So these are the various presentations of toxic encephalopathy, leukoencephalopathy type patterns. Ours usually fits into the posterior predominant or the white matter change leukoencephalopathy. But the history there's a particular importance in the history. If Prithija, now you want to probably give us the additional history of this patient.
Yes, sir. So on further inquiry, we came to know that the child's friend informed the parents that he had history of snake bite in the school. While he was playing in the ground, there was history of snake bite. And on examination, after 24 hours, we saw this snake fang mark that was on the lateral aspect of the right foot, sir. That was one history that we came to know later after the child was intubated.
Not in the school. After school, they went out to play in the fields.
But we don't know which snake, I guess. So it's obviously, I mean, it's a neurotoxic venom. So
Yeah. So it
changes
has
are.
caused respiratory failure. It has caused respiratory failure, and then before he could be ventilated and stabilized, probably had hypoxic injury.
Yeah, yeah.
And that is what we thought.
So it's a combination of hypoxic injury with these reversible leukoencephalopathy or leukoencephalopathy related changes related to the venom toxicity, which you're seeing on the scan, I guess. I think Dr. Kamte has published a couple of case reports. I'm not sure if it's there on the panelists to comment upon, but if anyone has further similar experience with snake venom bite and brain changes, most welcome to comment upon. Thanks.
Do you have a follow-up on this, on the course? How is the prognosis of this venom-induced white matter change?
He neurologically was significantly encephalopathic for almost next 10 days. And because of the long-term implications, they took the child to a government facility for a tracheostomy and management.
Now he's on tracheostomy. Sensorium is not so good, but he's on tracheostomy and on ventilatory supports.
So, Dr. Nihaal, I had a question because mostly cobra is supposed to be neurotoxic. So, have they described in literature any this kind particular kind of abnormalities on the MRI with cobra bite?
The particularly described neurotoxic ones, these are the ones from literature. I haven't seen if cobra was the snake involved, but I know one of the cases is from Dr. Kamte, where I think this is the one where they had these changes initially, which resembled our case, but on follow-up, you can see that there is a significant reduction in the MRI changes. So white matter changes and deep brain nuclear abnormalities have been described with neurotoxic venoms, but I have to check if cobra is the snake in these causative organism. I mean, the snake which has caused these changes.
Sure, sure. Out of the Indian snakes, I think cobra is the one which is supposed to be neurotoxic. Okay.
Nihaal, if I can come in our case, no, our case did not have any shock or the child, our patient had hypertension actually. When he came to the casualty to the peripheral hospital, the child did not have any cardiac arrest and all. And when we did a repeat MRI after 3 weeks, no, there was a resolution of the changes. And my patient is under follow-up for more than 1.5 years now. He is like he's able to now sit with support and able to stand with support and take few steps. Cognitively is well preserved. It's not that bad. It is looking more like a toxin-induced damage than hypoxia. Yeah.
So was the snake identified, Dr. Kamte?
No, this boy had seen in the field, and then he had reported to the parents that the snake had bitten. Nobody could, and they had not caught the snake actually. Yeah.
Yeah. So the first image is from your paper. I do not have access to the entire manuscript, but yeah.
Okay.
Thank you. We move on to our next case from Dr. Vivek. Dr. Vivek, if you're there.
Yeah. So it's a 12-month-old boy who had an acute diarrheal illness with melena and fever. And then at admission had anemia and thrombocytopenia with oliguria, rising creatinine. And his complete blood count revealed schistocytes and reticulocytes suggestive of intravascular hemolysis. And he was encephalopathic. He was initially treated symptomatically, but within few days he had to be ventilated. And then an MRI brain was done. The possibility considered was thrombotic thrombocytopenic purpura.
Okay. So we have the MRI brain on top of the T2 axel sequences, confluent white matter abnormalities, bilateral cerebral hemispheres, with some areas of central hyperintensities which are more prominent than the adjacent white matter changes, extending up to subcortical to white matter. Also, patchy areas of involvement of the bilateral thalami. Some areas of the corpus callosum are there. Coming down to the infratentorial structures, the vermis is involved, the dentate nucleus, especially on the right, is slightly more hyperintense than normal. Dorsal brainstem is slightly more hyperintense, and corresponding changes again on the flare sequences, periventricular to subcortical predominance, also involving the deep brain nuclear structures, more prominently the bilateral thalami, and infratentorial involvement. Diffusion-weighted sequences, you have these multifocal punctate or confluent areas of abnormalities, predominantly in the superficial and deep white matter, bilateral cerebral hemispheres, periventricular areas, demonstrating this punctate linear foci or restrictive diffusion. Also in the some areas of the cortex, in the anterior temporal lobe over there, and also in the bilateral cerebral hemispheres and the vermis. On the SWA sequences, you can appreciate that there are these confluent abnormalities demonstrate these linear areas of blooming, possibility suggestive of some hemorrhage over there, or a deep vein slow flow or thrombosis, especially in the medullary vein regions. So bilateral periventricular regions have these areas of blooming. Over here again in the peritrigonal regions, and again in the right anterior frontal white matter has this focal area of blooming change on the SWA sequences. I'm not sure if a contrast was done, Dr. Vivek. I don't think they have a contrast sequence. So the question was, can these changes be associated with thrombocytopenic purpura and hemolytic uremic syndrome? Or is there any possibility of an involuntary metabolism such as mitochondrial disorder or vanishing white matter disease? I think the changes are primarily ischemic, whether they acquire or genetic, to be evaluated. These are the common changes associated with HUS and TTP. They are usually present that the breast-like changes can have these hemorrhagic foci, predominantly vascular ischemic changes, and also thought of a possibility of thalamic encephalopathy, though not commonly seen, but can have these periventricular deep white matter abnormalities, can also have this involvement of the central structures. And the possibility of mitochondria was raised, though they can have either restricted diffusion, but they are usually more confluent in nature, usually more positive predominant cavitary foci are demonstrated. There is involvement of the corpus callosum, especially in the leukodystrophies and the middle blade of the corpus callosum, which was not seen in our case. It was more punctate or not as confluent as normally described in the mitochondrial disorders. I wouldn't entertain the possibility of managing white matter at all, because these changes are, the diffusion changes in managing white matter are usually along the areas of spared refractory changes. So that is predominantly in the central white matter and the peripheral regions of the subcortical white matter rather than the periventricular and deep white matter. So diffusion pattern itself does not fit managing white matter. And on the flare also, there is no rarefaction demonstrated on imaging. So that possibility I wouldn't entertain at all.
So the child had methylpred and 3 cycles of plasmapheresis, and the extra neurological parameters have all improved, but he continues to be ventilated and encephalopathic. So that's it.
What is your final diagnosis? I'm not sure whether I understood it correctly. It's hemolytic uremic syndrome.
So if it involves the brain with HUS, as I understand, then you would call it more of thrombotic thrombocytopenic purpura. So TTP is what we have provisionally kept as the diagnosis.
And just so I understand, I mean, normally for HUS, particularly if you have neuro involvement, you give eculizumab. Is that something that you would consider? The anti-complement.
So we don't have it here, as I understand. So we stopped at plasmapheresis, and because parameters improve, extra neurological, so they just improved after 2 cycles of plasmapheresis.
Okay, but you continued for 5, did you say, no?
So what my intensivist was of the view, so and I might and I might be wrong, what I understood what he said. Said in pediatric age group, especially in the first few years, you do daily 3 cycles every day, not alternate day. Wait for 2-3 days and see for the response. And it's a good response because 95% of antibodies would be removed in 3 cycles. So then you don't need to do 2 more. As in adults or older children, where you do 1 every alternate day for 5 cycles.
So we do 5. Yeah, I don't know. I actually treat and maybe just the protocol. I mean, you may be right. I do 5, but we have a very good plasma exchange team that come and do it. And actually, normally they would do 2 in a row and maybe give a day rest and then do like so. It probably takes a week. So they tend to do 5 cycles in 1 week. And I generally don't do more than 5 cycles. I know some people, I don't know, do 10. I generally just do 5 and see. I think the key thing is that, I mean, would you give steroids? How is he neurologically now? I mean, the brain looks quite bad, but clinically?
So we did give methylpred pulse, and he's on oral steroid now.
Okay, fine. Okay. Yeah. And as long as you're seeing improvements, you can just hold off escalating.
He is not improved much. He's not deteriorated, but not improved much. He's still encephalopathic, now on tracheostomy.
Oh wow!
But
okay.
His neurological parameters have improved. All of that.
Tricky.
Can I make a simple comment? Differential diagnosis. Here is mentioned schistocytes, which means fragmented erythrocytes. This, if this is true, is of course against a mitochondrial disorder and vanishing white matter, and is absolutely in keeping whatever you call it. You would call it hemolytic uremic syndrome.
Completely agree. It's just the radiologist had given those differentials, so I just put them there.
Right. Thanks, Dr. and CL.
Is this something to try to see if you can get, if the child is still so medically unwell, would you consider speaking to the company about using it in a compassionate?
Sure. So your endpoint should be the extra neurological parameters is improved, or the neurological damage, which might be a sequelae rather than a ongoing process.
I think it's this is the bit that is a bit unknown, and I think the question is, the question is, if you would have given equilizumab, would you have prevented the neurological thing? How much of it? And I think some of it is also to do with Joe.
Hello.
No, I was just wondering if we feel, as a group, that this is end stage and there's nothing else to do, and this is just sequential to what has happened, or. But you're still treating him with steroids, so you are hoping that some of it would be reversible, no?
Yeah, initially steroids IV, but now oral steroids. So not necessarily we hope that oral steroids is going to, but it's the protocol, isn't it? We just give steroids in the initial phase and just give oral steroids afterwards, in the hope that over the next few months it will have some more effect, rather than giving it because that I'm hoping that this will work. It's often
exactly. So I think if we feel that there is a treatable element and he's making partial response but not an amazing response, then we need to wonder if escalating the immunosuppression could potentially, with the associated risk, may result in better outcome.
Sure.
Is there a pathophysiological information that the brain improves slower than the disease clears slower than the peripheral markers? That might be a good case to make if there is that information.
And was there any enhancement in the brain? I saw you may mention it.
No, I don't.
Unfortunately, we didn't have contrast image. Yeah, it was a shame. So Yale, is that something which helps you also to be how aggressive with the treatment? Because often we are in this situation where you don't know whether if you go on for plasma.
No, I totally agree. I think we don't know. I'm only basing it, and bear in mind for us we actually just looking at it. So I may have some more. We've got the list of all the patients with HOS. We're trying to see what predisposed them to have neurological input. But the question, so the question is, if eculizumab would have been available in your center, would you have then given it?
Yeah, so I was not aware of that therapy, but if that is something which is helpful, and if it doesn't, so the problem is the healthcare system is private in India often.
Yeah, and
So
it's, I think
families
it's an
have to pay for it.
expensive.
Yeah. It's an expensive, is it?
I think it's an expensive drug, but I wonder if it's and you had the E. coli positive HUS.
So E. coli was negative.
Okay.
Yeah. So yeah, there was a generic question, not just TTP, for any illness. When you take a decision, so methylpred is easy to give. So one starts methylpred. But beyond that, because for us it's
beyond
always
that,
costly.
it's very, very difficult. And I think one of the problem is that in this world of monoclonal antibodies, you can pick the wrong treatment. So, you know, generally, I think the acute treatment is really only the steroids, the IVIG, and the plasma exchange. So there's an element of how much you can do for the acute treatment. Then you can sometimes rationalize. So, for example, you have a few agents that may work in the acute setting, but they take a bit longer to work. So, you know, if you have like an Aquapoint 4 and you think actually, you know, whilst we're giving the Plex and everything else, let's give some rituximab also. So this is or as we do with NMD encephalitis, we give rituximab. I don't even do Plex for NMD encephalitis. I give rituximab first line. And then within like 3-4 weeks, they start improving. If you have conditions like MOG, for example, you know, rituximab doesn't tend to work. You know, generally, I don't use it that much. So this is a condition that maybe I will keep the steroids on for a bit longer, or I would consider monthly IVIG even from the beginning to try to see how things are working. Then you have a group of patients that you don't know the pathobiology of what's causing this. And they're patients that you see in the intensive care, and you sometimes even do brain biopsies, and they only show like non-specific inflammation, and you're a bit stuck. And in these patients, you know, some of them you may see improve or partial improvement to methylpred or IVIG, and some of them you're really kind of just treating them because of you have nothing to lose. And with these patients, what I try to do is either I try to get the CSF cytokines. So I've had 2 patients I've used tocilizumab based on raised CSF cytokines without actually knowing what was the diagnosis. But in both of them, they had very high CSF IL-6, and that's how we decided to use that, and it worked. And what I've used also in a few times in those patients that you really don't know what's going on, but you feel like there's a lot of CNS inflammation and there's nothing systemically. It's things like natalizumab has been used in the acute setting sometimes just to stop the inflammation going into the brain. That's it's not easy. It's never easy, but you just have to kind of do it rationalizing.
Yeah, because 2 of my fires patient had very high IL-6. I gave tocilizumab, CSF IL-6, and they both had severe sepsis later on, and one of them succumbed. So it's a double-edged sword.
Yeah, fires is our epileptologists deal with them. I'm never really sure that there is I'm not sure they're all the same phenotype. But I agree, if there's very high IL-6, but IL-6, it can come from 2 pathways. Be antibody that, so it's tricky, but I agree, I probably.
So you did mention eculizumab is something one could use.
I only use
eculizumab
because no, I only mention it because that's part of the treatment of HUS.
Okay.
So my understanding from our renal doctors, but not somebody just mentioned it cost 21,000. We don't normally get involved, but our nephrologists normally with the HUS, if the patient fulfill a certain number of criteria, they escalate it to eculizumab. And I think CNS involvement is one of these criteria.
Okay.
It may be worth discussing it with a nephrologist. Number 1, asking, is this typical HUS? Number 2, do we need to look for anything else? They think this is typical HUS, and if there's brain, there is brain involvement, then at least in my institute, they normally would have given it. I don't normally get involved. we sometimes come to prognosticate, but actually it's there the nephrologist for.
Right.
Vivek,
Yes, sir.
I had a question. There was a basic ganglia involvement. I came in a bit late, so I didn't see this.
Thalamic?
Thalamic,
Basic
yes.
ganglia, I'm talking about corpus striatum. I think there's no involvement, right?
Yeah, it's relatively spread.
Supposed to be
Possibly.
quite typical for HUS.
Okay, yeah. So I had a case just 3 months back, and that's what my understanding was, that that child had typical putamen swelling, like you see in those DR2 type encephalitis, and those type of disorders, where you have, right? Is that right, Dr. Dana? That's how it is. Looks complete, both sides swollen. So this was odd.
This is odd, definitely. Anyway.
So just wanted to add a recent experience. We are right now struggling with a patient with fires, and this girl has got bilateral posterior putaminal hyperintensities, nothing else in the MRI. And we did the IL-6 levels, which came to be normal. Still, we went ahead and gave tocilizumab because we were just not able to come off the general anesthetics after even 1.5 weeks. Though it has not really made much difference, only thing we could at least bring the medals from maybe 2018 to 6 and maintain on high dose Loraz and all the other things. The pleds are going on, the seizures are still going on, multifocal small ones. So our intensivist found out that there is something called tofacitinib. Maybe I'm not pronouncing it correctly. It is supposed to be JAK1 inhibitor, which has a good CNS penetration. And because we could not give any
Sorry,
further
which inhibitor?
tocilizumab.
What is it?
JAK1.
It is
JAK inhibitor.
CNS inhibitor.
Yeah.
And it has a good CNS penetration, and so now they have started it. So I really
But these
recommend we are just to be
medications,
very
we use a
experimental, I
lot
think.
of them
Yeah.
for like the genetic HLH. They're not without side effects. You get into terrible infections with these medications, and sometimes the infection makes the inflammation worse. So I don't think we should just particularly with those fires that people, Helen Cross always say that there was this one child for fires for 3 years and somebody missed the focal cortical dysplasia. So I think that group of fires is such a difficult to define group that we need to be really careful with throwing monoclonal antibodies on them.
Yeah,
well, that's my
what I mean.
personal
The
opinion.
IL-6 is not very high. I don't know how
Particularly,
far
I
to go
mean, I think if the
immunotherapies,
because normally if you look at the HLH, the patients that we end up giving the JAK inhibitors are the ones that have multiple cytokines raised. So if you see when you do the CSF cytokines that the IL-1 and the IL-6, maybe the TNF alpha are all raised, then that would go one level below and block them all. But we have got into terrible problems with infection. Our last patient that we used there, actually, I mean, he had a Gracilli syndrome, but he actually died because we couldn't get him ready for a transplant because he got so many infections from the JAK inhibitor. So with him, we had no choice. We had a genetic HLH, but I think just need to be a bit careful. They have short half-life, so in that way, it's not, but still.
I think we'll go on to the next case. Thank you.
Thanks, everyone. Jayant, if you're there, or Dr. Shiji?
Yeah. I'm presenting a case of 14-year-old boy. He's a known case of beta thal major, and he's been transfusion dependent since 2 years of age, and now he's admitted for an open splenectomy. He had all the indications of a splenectomy. He had hypersplenism and pancytopenia. And this child had an intra-op complication of gastric perforation, peritonitis, and stomy intra-op and perioperative course. And after that, he has recovered on day 4, post-operative day 4. He was shifted back to the ward from the ICU. On post-op day 7, this boy started having sudden onset swaying gait and intensive tremors. And on examination, he had all the signs of cerebellar dysfunction. So he had finger nose test positive, tandem walking positive, and dysdiadochokinesia as well. Apart from that, the rest of the examination was completely normal. His higher mental functions were normal, and no other deficits were seen. So with this in the background, the hemogram after the surgery, it was around 8. He had an intraoperative hemorrhage, and TLC was 3,400, platelets of 1.2, and rest of the function tests were normal. And the coagulation screen was also normal. And we had a basal workup for stroke done lipid profile 2D echo and homocysteine was normal. And this child had a serum ferritin fairly high since last few years. It was poorly controlled. The iron deletion was not correctly going on. So we thought we should get an MRI with an MR angio. The scans to follow.
Yeah, so these are from the images, so slightly slated, but we have the diffusion on the left and the ADC on the right, and the abnormalities that stand out are the areas of concurrent area restricted diffusion in the deep white matter extending up this subcortical white matter, predominantly in the midfrontal regions and also in the parietal lobes. I cannot appreciate anything in the central regions, the deep brain nuclei or the cortex. Yeah, so based on these images, I'm seeing predominant involvement of the deep and superficial frontal and parietal white matter. On the T2 various sequences, I can appreciate some cortical atrophy, generalized cortical atrophy on both sides. And there is hypertrophy of the calvarium that is expected for an anemic child or child with thalassemia. Better appreciate on the parietal images, you can appreciate that the marrow is of the calvarium is dark and is expanded. No CVG abnormalities per se. There's no significant crowding of the cranial junction structures or the posterior fossa structures. So generalized cortical atrophy with those white matter, subacute white matter changes on the MRI. The SWS sequences, there are no focal areas of hemosiderin or calcification. With the angio, I don't have a source image again. These are only MIP images, and you can appreciate this alternating flow of beaded appearance in the bilateral vertebral arteries, almost like a string of bead appearance, which you typically see in commonly see in fibromuscular dysplasia and vasculitic syndromes. But yeah, these are the beaded appearance of the bilateral vertebral arteries. A venogram was done, and I cannot appreciate any abnormalities on the venogram other than the hyperplastic right-sided system that is likely to be a normal variant. The transverse sinus, sigma sinus, and the IJB are slightly hyperplastic in comparison to the left. The question was, Jen, what was the primary question?
Yeah, so the bilateral symmetric beading, there was one report mentioned in a similar case. So do we take this for sure as a hemopoiesis related compression of vertebral artery across the transverse foramen transversarium, or do we need to consider other causes? Because this child improved spontaneously. We haven't proceeded further with the workup or treatment. So how is the prognosis? What could be the probable cause of this beading?
Yeah, so I don't have the images across the transverse to check if there's narrowing or not.
Okay.
But I haven't come across that case report. So if there was a finding of the bony abnormality over there with the
the case which was mentioned was from Delhi, from Lady Haring. So they had a similar case of with exactly compression at the foramen transversarium, and it was symmetric across the vertebral arteries.
Okay.
So they have mentioned it is because of the foramen compression because of marrow expansion.
Yeah, marrow expansion. That probably explains, because vasculitis involves the symmetrical abnormalities on both sides for an inflammatory condition, that be slightly atypical. I would probably put that, but I would need evidence of the bony abnormality, or possibly a CT scan to be done.
All right. So CT angio would be a better.
CT angio should be helpful on this.
All right.
And regarding the white matter changes, any electrolyte abnormalities?
No, none.
Dysfunctions?
No, electrolytes were normal.
Or acute leukoencephalopathy type pattern, but I'm not sure what is the cause.
The diffusion restriction in the white matter that has also been described in cases of beta thal because of chronic ischemic changes, chronic hypoxia because of hemolytic disease. But we were not sure about the beading, so should we go ahead?
The beading is fine, but the white matter changes are more acute, rather than chronic. So
all right.
It looks like something related to the metabolic derangement, but yeah, I'm not sure of the exact cause.
Okay.
If anyone wants to, I'll open the case for the panelists. We have seen similar cases for dialysis dysequilibrium syndrome, but that is because of rapid dialysis, which causes this derangement of the metabolites. But
yeah.
Yeah, so Dr. Lokesh agrees with the vertebral artery changes.
So would this be progressive? I mean, do we have to do a serial scans and check, or we have started this child on aspirin? So anything else can be done for this? Anyone from the panelists would?
Is there any medication or something which reduces the marrow expansion? That will probably be the cause of treatment. I mean,
I think bone marrow transplant.
Transplant, yeah.
So,
Yeah, great. Transplant is the answer.
All right, sir.
you probably just check the follow-up scan if the white matter changes are still there.
All right.
I'm expecting them to be transient, so related to something with the kidney injury or acute kidney injury, causing some metabolic derangement. So if they resolve, then you can probably attribute it to one of those causes.
All right. So would you consider giving low molecular heparin if this comes back, if it's recurrent, or only aspirin would do? Any thoughts on that?
I mean, I'm sure these are ischemic.
They're not ischemic for me, Dr. Dani.
So if they're not ischemic, I mean, what are you, because I assume that the bleeding of the vertebral arteries is very interesting. I was never aware of this, but I'm saying is that's not probably the cause of what's happening.
Yeah, that's more along the posterior circulation. This is more along the supratentorial region. So I don't think there is.
I thought the cerebellar ataxia, which had an acute onset, that was because of the posterior vertebral artery involvement in the compromise. But luckily, that was very transient, and 2 or 3 days the child was fine.
Yeah, Bow-Hunter syndrome like presentation, even with normal looking vessels, are very much possible, and this child is at very high risk for those kind of manifestations.
Okay.
So have you offered surgery to them, Dr. Lokesh?
This is Dr. Shiji's.
Yeah. So
no, in your cases.
Okay.
We have done 9 surgeries in 9 children, but we have never seen bleeding in any of them. It is all dynamic compression or a constant some of the basilar imagination or apparent axial dislocation causing the posterior circulation abnormalities. There we have done surgeries, and C1, C2 fixation we have done in 5 of them.
Okay, thanks.
So next would be CT with CT angio, Jayant, and then
we'll try getting a CT angio if the symptoms come back.
And also in flexion and extension.
All right.
Over to Meetu if you're there.
Yeah, yes, sir, I'm here. Sir, this is a 2-year-old male child born of 3rd-degree consanguineous marriage, 3rd by birth order, with normal birth history and developmental history, presented with complaints of fever, cough, cold for 5 to 6 days, 1 episode of seizure followed by altered sensorium. On examination, patient had spasticity, dystonia, brisk reflexes, and extensor plantar. Investigation, CSF showed pleocytosis with 180 cells, predominantly lymphocytic, 90%, with mildly raised protein and glucose is normal, and MRI brain done was suggestive of demyelination. Serum MOG antibody was also done, which came to be positive. COVID antibody was also positive. The patient was treated with methylprednisolone and IVIG, and patient improved and discharged.
Okay, so these are the.
So these are current. Yes, these are the MRI at the presentation.
Okay, so I have non-contrast phase sequences, and you can appreciate that there is predominant deep brain nuclear involvement, the basal ganglia, the anterior and mid segments, and also the thalamus, the bilateral thalami, demonstrating these edematous changes. Coming down again, the peninsular white matter also has some T2, some fair hyperintensities over there. Brainstem also demonstrates these hyperintense changes. The medial temporal lobes also are slightly hyperintense. Yeah, so again, dorsal brainstem is hyperintense. The vermis shows some hyperintensities, but the question is, was this child under anesthesia at the time of scan?
No, sir.
Because there are sulcal hyperintensities which are commonly seen in while giving IV anesthesia or hyperbaric oxygen. So that can
Okay,
be a
Okay.
pseudo-sulcal hyperintense sign. I mean, something like that. So thinking of that, yeah. So the follow-up, you have got MOG positive, and this was an abnormal.
So, sir, we did a follow-up. Though after the treatment, patient improved, and we discharged the patient, and we followed up with MRI, repeat MRI, and MOG antibody after 3 months. And the repeat MOG antibody was weakly positive, and MRI showed new lesion.
Okay, so just to demonstrate, the first scan has typical changes of MOG-related antibody-related disorders. So yeah, this is after 3 months.
The child was completely improved. There was no spasticity or dystonia, and MOG antibody was weakly positive, but the MRI showed new lesions. So the question is, are these lesions to be considered as radiological relapse, and should we consider treatment for relapse?
No, so categorically, this is now very well recognized now with MOG that they get radiological lag. So, you know, these lesions may kind of happen after you did the first MRI before he got completely back to normal. Yeah, so you tend to do the MRI in the ear and then the lesions. So actually about 30% of patients with MOG with ADEM, if not more than that, when you do a follow-up MRI at like 2-3 months after, they have some new lesions. But that new lesion are likely to have happened when you did the MRI a few days after. So it's a moving target, yeah? And this is one of the reasons I've now started to do follow-up MRI, if possible, on all of these ADEM, because then a couple of years later, they come in with some headache and somebody do a scan, and then there's some new lesions. So it's always good to re-baseline in these patients, because in the acute attack, there's definitely a radiological lag that you may have new lesion. And it's not uncommon that you see, as you're seeing here, some improvement of some of the lesion and some new lesion happening. We have actually looked at it, and we didn't find that in those patients that you get new MRI lesion at the first follow-up, they're more likely to have a relapse within the year. But this is still not published. But the radiological
when are you
lag
doing
is
that? Sorry, when are you doing that first follow-up MRI?
So I tend to do it after I stop the steroids.
Okay.
Yeah, but so I normally don't give. I think you guys give more steroids than me. I normally give 4 weeks, maximum 6 weeks if they're really severe. And then so I tend to kind of repeat the MRI at like 2-3 months. So then I have a baseline MRI clinical examination when they have kind of recovered from their ADEM. So if they're new lesion, you kind of, you have a new baseline to look for. You definitely don't count it as a relapse.
Okay.
Nihaal, I had a question.
Yeah.
What do you think of the volume of the putamen?
They're atrophied. So I had the same question, and I thought you need to consider the basal ganglia or the dorsal striatal necrosis kind of lesions. Because I haven't seen a follow-up, of case of ADEM with these
No, there's an entity called MOG encephalitis. It was reported from Spain, if I remember right. And in that you get these atrophic changes, but apparently the kids don't do very well. In this case, of course, it's done very well. So, generally ADEM the radiological findings in MOG, usually improve faster than the ADEM which is associated with non-MOG. And in this case, there's actually atrophy. It's a little odd. What do you think, Yale?
I think we lost her. So
Yeah, she had messaged. She was not able to hear.
So these were the only images I had, so I'm not sure of the extent of the new lesions and old lesions. I didn't have a diffusion. Also,
so there was no diffusion restriction. These were the only lesions.
So I can say maybe the periventricular white matter, but the thalamic ones have improved. They're almost completely resolved. But these putamen atrophic glycotic changes.
Yes, these are new.
I don't think they are new. I think
Okay, sir. Yeah.
these are more chronic changes, but they are rather more symmetrical and showing gliosis over there, by necrosis of gliosis. But these are not new changes, radiologically.
Okay. Oh,
Was the kid
okay.
very sick when he came? I mean, I missed the history. Was it just
Sir, he had altered sensorium. He had GCS of 7/15.
for a long time, is it?
No, sir, for a day or two. Then we got the MRI and we treated, and he improved within next 2 to 3 days.
Okay.
Can I just ask, since we're discussing the smog antibodies, how long do people give disease-modifying treatment for?
Well, if it is ADEM, generally you don't give because the MOG antibody comes down very fast, and there's no reason for relapse is not that common. But in when you have the opticospinal kind of thing, generally, people tend to use immunotherapy on a chronic basis.
No, after first event, I mean, most of my optic neuritis patients, even if they're bilateral, are monophasic. So I think it's a bit dependent. At least in pediatrics, we don't tend to treat after first attack. Half the optic neuritis that we've previously seen and half the ADEM patients that we've seen before the MOG was discovered were MOG. So we never really treated them. So I'm not sure that we definitely know that if now we have the antibody, we should treat differently. The difference is that we may choose if they do relapse, we treat them a bit differently than we treat Acupoint 4.
If they've relapsed, how long would you give the disease
So
modifying?
even that, so I think it's very much depend on, if they have one relapse, that when you wean off the steroids, and some people, may just give monthly IVIG for like a year and see. If you start MMF, most people do it for like 2 years. I think it's also depend on that, but definitely the consensus is not to keep these patients on disease-modifying treatment for life, as you would do with Acupoint 4. So there was ECTRIM, which was the MS organization meeting about a couple of weeks ago, and we discussed that in MS we shouldn't, although we're getting into good response with treatment, we're not really at the stage of recommend de-escalation. In Acupoint 4, definitely not. There's a study actually that is coming from the French group showing that patients relapse very quickly if you stop treatment. But I think MOG is the only disease that we encourage considering stopping treatment after a couple of years of disease stability. And I've definitely done it for quite a few of my patients, even the really kind of the one that for years we didn't know what it was. I knew it's MOG, and we had one patient that had about 30 relapses, then had 5 years of no relapses on IVIG, and I spaced the IVIG and then I stopped them. But generally, I definitely don't treat.
Yeah, that's good. You said that wean steroids early, because most of the papers recommend weaning steroids over 3 months, 6 months, and the ophthalmologists were telling me that the incidence of subcapsular cataract is high when you give a longer duration of steroids. So it's interesting that you wean it very, very early.
Yeah, just a question.
Sorry, I got cut off. Did you? At what point did I get cut off?
No, there's a question which Hudani also has mentioned, that on the follow-up MRI, there's you see that the bilateral dorsal striatum, especially the putamen, are atrophied and gliotic.
Can you hear me or not?
Yeah, I can hear you. Am I audible?
Have I been
Yeah,
disconnected?
am I audible? Sorry.
You are, yes.
Yeah, sorry.
Yes, yes, sir.
Okay, we'll probably take the question on the striatum in the chat because we are kind of running late. So yeah. To our next question, to our next presentation, Anas, if you're there.
Yeah. This is about a 13-year-old male child born to third-degree consanguineous parents. Other two siblings are okay. Child was apparently well, developmentally normal prior to this event. He had fever for 1 week. And then later he was affable for the next 2 days. And then developed behavioral issues in the form of inappropriate laughter, not indicating toilet needs, and reduced speech output. On examination, his eye contact was good, but he was emotionally labile. His laughing and smiling inappropriately. Motor examination was normal. Some mild ataxic gait. For this above complaint, he was admitted and started on methylprednisolone. On the third day, his symptoms started to improve. His emotional ability had improved. He got discharged on oral prednisolone. 2 months later, he had developed erythematous rash over the palms and sole, and some finger pains and oral ulceration, which resolved over 5 to 7 days, for which he was evaluated outside in rheumatological.
Okay, so this child has 3 sets of MRIs. So I'm assuming that after the first MRI, you started the methylpred. Is that right?
Yes, sir. Yes.
Okay. So we'll have a look at the MRI. So this is in August 22. Coming down to the lower images, the diffusion various sequences, you have these focal abnormalities in the deep white matter, the periventricular white matter, in the bilateral frontal lobes, some areas in the lower perisylvian region on the left. So restricted diffusion over there with corresponding hyperintense changes on the T2 weighted sequences. There is some degree of cortical atrophy in the bilateral cerebral hemispheres. Could not appreciate any signal abnormalities in the brainstem or the cerebellum. So these subacute is looking like ischemic changes in the or acute demyelinating changes in the bilateral frontal regions. Yeah, on the sagittal images, slightly pixelated again, but you can appreciate the volume loss of the supratemporal structures, thinning of the corpus callosum. The corpus callosum itself is spared in terms of the lesions, and you can appreciate the periventricular white matter changes on the sagittal images over there. And then a follow-up scan in October 22, that is after 2 months, and you can see that they're slightly more confluent in nature. The white matter changes have extended now into the parietal lobes, the temporal lobes. You can appreciate that the previous lesions are now demonstrating cavitatory changes, and glyvasis over there. I don't have the diffusion sequences, but there were no area diffusion or abnormalities on the diffusion or ADC sequences. No hemosiderin or calcifications on the SWI sequences. Post-contrast study was done, and there was no significant enhancement in the abnormal areas or in the meninges. Again, on the sagittal image, you can appreciate that there is some degree of volume loss in the supratemporal brain structures. Feb 2023, compared to the October scan, the lesions look pretty similar in the supratemporal structures, that is primarily in the frontal lobes, but there were additional findings of these anterior temporal pole subcortical white matter changes, which I think were not there on the, they were there, but not as the slight progression in the scan in Feb 2023. Again, corpus callosum, the brainstem, cerebellum, the visualized cervical cord did not demonstrate any signal changes. The question was, Anas, we're thinking of ischemic lesions, demyelination, and a possibility of a genetic cerebrovascular disease such as NOTCH3 mutation. Were the differentials which we considered? So Anas, clinically and clinical diagnosis and the radiological interpretation.
Clinically, so when the child was evaluated initially, EEG was done, was no intrarectal discharges, good sleep markers. CSF was done, which showed normal, protein was 10, sugars 57, cells were 10, all lymphocytes. CSF viral panel was sent, which showed CMV PCR positive. CSF for NMDR was also sent, was negative. Serum NMO was normal as well. Inflammatory markers were normal as well. The 2 months later, when he presented, at that time his sensorium and other behavioral changes had improved. But only thing is he had some inflammatory changes like rash and painful joints, for which he was evaluated by a rheumatologist. The workup for rheumatology, ANCA, C-ANCA, P-ANCA, and workup for ANA was all normal. So the only positive thing we found in the whole workup was CSF CMV PCR. So The child is improving as of now. He is back to baseline. His behavioral and indicating toilet needs, everything is okay. Right now, he's on low dose prednisolone. Genetics was done as well. Whole exome sequencing, which was normal.
And they specifically look at all the carousel and cadacil. You know, there's a part of the cadacil. There's all these other one. I think the other one is carousel, and these are the ones that mainly in adult onset leukodystrophy, looking a bit like this. That present just with headaches, and you get this florid MRI. So I'm just wondering that with the exome, whether they had a good look for those specific genes. Because to me, it doesn't look like demyelination, and also with this history, carousel. With this history, it doesn't really feel like necessarily a vasculitis. No, I mean it's quite unusual to have CNS only vasculitis in children anyway, and the presentation is not very typical, and the MRI is not very typical. So, you know, I would go more to one of those. Genetics mimic would seems more likely, or even I don't know what the radiologists feel.
Yeah, I agree.
You know, and I guess some of them you may miss in the exome, but particularly in a child that is so well clinically with this type of MRI. Do we think any of it is calcification? Because that kind of
no, there was
into one. There are no calcifications. They're just very unusual changes. It doesn't look like demyelination. And did we say there is a spinal cord involvement also? Or?
No, there's no spinal cord.
Yeah. Okay. So anything in the eyes?
On us? Nothing on the imaging, but
yeah. I don't know. To me, I would kind of have him whether he even needs a whole genome or something. I don't know. To me, it feels very genetic, and I would worry a bit about escalating immunosuppression just to treat the scan. But then, if the scan is progressive, I see why it's stressful. But I think we need to know what we're dealing with. Yeah, it kind of reminded me. I see the carousel looks. I don't know if anybody wants to pull the paper. It looks the one patient that I've seen with it looks quite similar, and it was like a migraine history.
No hypertension, right?
Anas? No hypertension, I guess. Yeah. Nothing in these people. Yeah, no hypertension. You have Dr. Ramesh on the chat.
Frankly, I've never seen carousel in children, but I don't know.
Yeah, it was also slightly.
No, I agree, but in a sense, it also doesn't look like any of the acquired condition that we see. No.
I agree. I'm first I was thinking it's a vasculitis because of the initial MRI showed, and then there's cavitation, and then there's a rash, and there's ulceration and stuff like that. But
yeah, and I think the other striking thing is how abnormal the scan is and how well the child. So it's kind of another clue. No, I mean, I'm not seeing the child, but that's the feeling I'm getting.
Yeah, child is doing well, ma'am. He's academically performing
exactly.
well.
So the child is really well, and the scan is very abnormal. So that's kind of why makes me think about some of these conditions.
No, isn't it possible there's some sort of acute problem which is now resolved by itself and left some changes in the MRI? Some sort of. You're saying it's not demyelination, but I agree with that. But I don't know.
Yeah, I mean, it is possible, but I'm just thinking if, for example, this would have been a viral infection, giving you all of this, like, I don't know, let's call them gliotic changes, although we're not sure what they are. Wouldn't you expect the child to have some more abnormalities? This is the bit that is a bit unusual. If this was like a vasculitis or an infective condition, you would expect the child to have some motor problems or some, no?
I agree. Difficult to explain.
there's a comment saying clinically he's behaving like a one-time injury. Does he have neurological signs? Is he walking? Is he unlimited, or can he run?
No motor, no deficits as of now, ma'am. He's asymptomatic back to baseline.
Okay. So in a way, if you have a one-time insult with such a extensive scarring, you would expect a bit more abnormalities, wouldn't you?
Very plastic, the brain at this age.
Exactly. So that's why it reminded me of all. I'm only thinking about it because of all these leukodystrophy in adults. A lot of the time they get picked up like with a bit of dizziness or a bit of, so it just reminded me a bit in that sense of some of these kind of conditions. You have something really insignificant and then you suddenly find this really bad MRI and you don't know what to do with it. So
did you do homocysteine? I missed that.
Yes.
It would have been picked up in the exome, no? And it would have been picked up in the exome probably, no?
It is normal homocysteine.
Okay.
Okay. So we agree that for now to stop the PRED as kind of for normal weaning protocol, do nothing for now.
I think so. Yeah.
Yeah, and when would people repeat the MRI in a year?
Yeah, if he doesn't have any symptoms, person.
If he doesn't have any symptom, no more than a 1 a year scan.
Yeah,
thank you.
Yeah, thanks. Okay, over to you, Sahil.
Yes, sir. So, so she's a 12-year-old female born of first issue of third-degree consanguineous marriage and normal perinatal and developmental history with history of stroke in father. So she was a case of precocious puberty. She was diagnosed at 9 years of age, and initial scan had showed epidermoid cyst. So subsequently, for the progression of the epidermoid cyst, her scans were done. The last one being on 20, which had shown non-progression of scan. So, so later on, sir, you are going to the scan then.
What are the 20 scan? I have the 22 scan. It's okay.
Yeah, yes, sir. So, sir, during May 22, she came with difficulty of walking since 2 days, and she presented as right-sided foot drop. And that time, her MRI was done, sir, initially.
Okay.
Yes.
So after the foot drop, right side foot drop, the MRI, you can appreciate this focal lesion in the left flick, some also bordering onto the left ventricular thalami, demonstrating restricted diffusion over there. No hemorrhage or calcification. The cerebral peduncles also, there's some areas of restricted diffusion. Left is slightly more than the right. I could not appreciate a non-contrast flare, any optic neuritis or optic edema. So primary abnormality of the left flick and also some areas of the brainstem. The cord was screened and again could not appreciate any focal or long segment lesions involving the cervical, thoracic on the lumbar cord. So after that, sorry, yeah.
So after that, sir, she was started on aspirin outside, sir, and regained full function of the right foot within few days. And later on, the child had lost to follow up, and then came in October again with complaints of sudden onset left upper limb and lower limb weakness since Monday. On admissions, her vitals were stable. GCS was 15/15. The power of left upper limb and lower limb was 3/5. Rest was normal, sir. So this time when we went ahead with MRI, we had a different picture.
So this is the MR?
Yes, sir.
Okay. So on the follow-up MR, you can appreciate again new lesions.
No, sir. This is not the picture, sir. This is the other one. This is in March 23, the one which you are showing right now.
So that's the only one I have. Okay, so just tell us what was the findings, the new findings.
No? Sir, I had sent you the. So, sir, that time it had shown Sir, it had
Any
shown.
lesions?
Yes, sir. Yeah, just a minute, sir. Yes, sir. Sir, sir, at October scan, there were a subcortical white matter lesion in the centrum semiovale, sir. And along with that, there was a right occipital white matter hyperintensity, which was seen. These were the only two lesions that were seen in this child. And she was started on methylprednisolone, sir. Considering the possibility of autoimmune demyelination in this child. Her CSF was done, which was normal, sir. Cells were 8, proteins were 32, glucose were 80. But during this time, her CSF
Oligoclonal band?
Oligoclonal bands were negative. MOG and NMO, which was sent, which was negative. Her CSF IgG levels were raised, which were 44. For the vasculitis workup, we had done C-ANCA and P-ANCA, which turned out to be negative in this child. Her APLA profile was sent, which was negative. Anticardiolipin antibody was negative. And also we did venous and renal Doppler of all limbs, which were normal, and renal Doppler was also normal. So subsequently, she was discharged on Visalon and aspirin. So it gradually improved over the 5 days, the left hemiparesis. And further, they had lost to follow-up and they stopped their medication on their own. And in March, she again came with complaints of abnormal sensation over the left side of the face since 2 days. Rest of all, she was normal, and left eye shows lag of ophthalmos. There was no cranial nerve involvement apart from this. This time when her MRI was repeated, so this is the March which was showing.
Okay. So March on, we have again new lesions, bilateral frontal lobes, the subcortical white matter involving the cortical structures over there. Also in the left parietal lobe, the subcortical cortical regions demonstrating restricted diffusion. In the areas of the corona radiata or the tail of the caudate nucleus over there, you have this area of restricted focal area of restricted diffusion in the periventricular region. On the anterior segments of the corpus callosum on the left. And on the T2 and flare sequences, at least compared to the first scan, we don't have the images of the interval scan. We have these abnormalities in the superficial or deep white matter on both sides, and also in the periventricular white matter. And coming down to the posterior fossa structures, you can appreciate that especially the middle segment of peduncles are slightly hyperintense on flare and also on the T280 sequences. So this was not demonstrated on the initial scan. And this is a non-contrast flare sequence of the optic nerves. At least the intra-orbital segments of the optic nerves appear to be slightly reduced in caliber. The signal intensity is not that of a neuritis, but I can appreciate that at least the volume is slightly down in comparison to a normal optic nerve. T280 sequences, again, similar hyperintense changes, flares, similar changes. Post-contrast study, there was no enhancement of the abnormal lesions. The visualized cervical cord did not demonstrate any focal lesions. And again, non-contrast T2, no edematous changes. I think this is a follow-up side of the optic nerves and the spinal cord later on.
Yes, sir. Yes, sir.
What was the time interval?
So this was done after 5 months, sir.
So no, this was March 23rd.
Yes, sir. This was March 23rd. Yes, sir.
So this is all part of the same scan.
Yes, sir. This is all. This is a similar scan, sir.
So post-contrast optic nerves, not so much on the axial section, but the coronal sequences demonstrate some areas of enhancement over there in the bilateral optic nerves, predominantly in the intra-orbital segments. Spinal cord screening did not demonstrate any lesions. So yeah. So was this correlated on the fundoscopy of optic neuritis by any chance, or maybe?
No, sir. Currently we are treating on the lines of MS in this child, sir, because it is showing periventricular white matter hyperintensities.
Yeah.
And currently the child is doing well, and she's on mycophenolate mofetil, sir.
Why MMF for MS?
Actually, ma'am, what happened is the mother was insisting to give
Mother is actually working in our hospital only, and she has read a lot, and she said, I want only oral treatments. Then she went to some adult neurologist who said, you can give mycophenolate. So then she was very, very persistent that I want only that and nothing else. And we are,
yeah, but it's a shame. I mean, this looks like MS,
yeah.
quite active disease if you're looking at the accrual of new lesions. And you know, I start most of my patients on ocrelizumab. If their family is paying, I would probably use rituximab. But I think to treat MS with MMF is a bit. I don't know if I would even, because it gives her the risk, but I'm not sure about exactly the effect. I don't know. It's tricky, but if you want to use that, that you consulted. I mean, I think some of the old literature on pediatric MS using MMF, as we all know, 30% of the, if not more, in that age group. The majority of patients in this pediatric age group that were giving MMF for relapsing ADEM that was labeled MS were MOG. So I think, you know, these patients with those type of lesion, it's a bit like the evidence in adults. Nobody used in adults MS, MMF.
Yeah, so in adults, whatever literature we got, I mean, it looked encouraging, at least the Indian paper. So we thought, let us.
Well, using MMF for MS.
Yes, MMF for adult MS.
Also, it's a girl, no? I mean, it's like, how old is she?
I think 14.
She is
13-year-old.
Yeah, so I
13,
think
14,
I would, you know, in the UK they're very, you know, any girl post-pubertal that's going on MMF is a problem because you can't get pregnant on it. So, you know, it may be something that you can use to help the mom shift to rituximab.
Yeah, so the mother was pretty adamant about it, and so we have used this. So we just wanted to confirm whether this does look like MS, though clinically, of course, DIT, DIS, all those criteria are met.
So clinically, the relapses sound much more like MS than anything else. The lesions, I also agree, pattern-wise sounds most likely to be MS. So one thing that is slightly unusual is that the bands are negative, but actually you have raised IgG index. So, you know, sometimes it can even represent there's a lot of bands and they kind of call it background. So I don't know if sometimes you can even ask them to run the same sample. I don't know. What's your IgG index? What's the upper limit? Because we use different value. You said it came back as 47 or something, or 4.7?
Yes, ma'am. Yes, ma'am. The previous, which was 44, the upper limit.
And what's
the
your
upper range?
Limit?
Upper range is up to
24 or something. Just check
okay, so it's significantly raised. So it's likely that you do have oligoclonal bands. So it may be technical that they didn't see them if the IgG index is so high.
Yes, and even and ma'am, even during this episode in March that she came, we had repeated the oligoclonal bands again. This turned out to be negative, and the IgG level, just the report came 2 days back. It was 0.3, so it was decreased now.
Okay.
CSF IgG
difficult
level.
to. Yeah, the one thing that I sometimes find useful in those patients that maybe are a bit atypical, I mean, in the beginning you thought it was a stroke, so there were some atypical features, is that generally in MS, none of the lesions disappear. So in relapsing remitting MS, you only get new lesion. The lesion could go smaller, but they don't disappear. So it may be worse.
That's the case here as well,
Exactly. So because I didn't see all the scans. So if the lesions, so with all of those relapsing, like in the MOG and in the aquaporin and you normally see it's you know, some lesions disappearing, whereas in MS, none of the lesions disappear. So I made Kish look at 110 patient scan, and none of them disappear.
So here they appear to become smaller, but not disappear.
Exactly, but in MOG they disappear, in aquaporin 4 they disappear, you know, in some other conditions, but in MS they never disappear. So I find it very useful. Sometimes if you kind of go, oh, this is a bit like, really it's MS is the key one, the lesions don't disappear, they stay. And I also think with the family there's a bit kind of tricky. If you can convince them to go on rituximab, so somebody asked, I would just give it like in the MS protocol, so every 6 months. You don't need to necessarily
Try to
monitor the B
convince them
cells
again
like.
that we have spoken to the best expert, and that is what the
But who is
opinion
the best expert? Best expert told them to go on MMF.
No. I'm saying that we will tell her that we have spoken to the best expert. That's you, and try to
Okay.
convince her again.
Sorry, I thought, yeah. Please, I use my name. I don't
Yeah.
mind, but I really feel like
Yeah.
at this young age, it's a shame not to treat them appropriately. And also, if you give them the rituximab, the patients feel better. Ocrelizumab, it's amazing. My patients, they feel so good.
That's what our plan
the fatigue goes, everything goes. And I also tell that if you want to use my name, also say that I was very concerned about MMF given in a teenager girl. That hopefully would scare her.
Sure.
Yeah, so use
yeah.
And if you want me to put something in writing, I'm very happy to do.
Sure. That would be very nice.
But rituximab every 6 months. So you give, you start the induction a bit like you do with other condition, and then once you've given, the induction I do per weight. So 750 per meter square twice every 2 weeks. And then the follow-up, if she's over 40 kilograms, which I'm sure she is, you just give 1 gram, 1 dose every 6 months.
Well, thanks, Hill.
Can I come back to the history, not relevant? You mentioned epidermoid cyst. Where was it?
Yeah,
Where
it
is
was in the
location?
left CP angle. I think I missed that. Here.
So actually, that was another question which was on our mind, whether that cyst is actually compressing, the fifth nerve, and current symptoms are related to that.
No, it's not
That
around.
was,
They're usually more anterior. So yeah, I don't think it compresses the fifth.
Okay, thanks.
So quick, next one.
Yeah. Sir, this is Zian Khan, sir.
Okay. Sorry. Okay, go ahead with the presentation.
Yes, sir. I have the history. I'll tell. So he's a 5.5-year-old male child. So he is born of second issue of non-conjugacy married parents, normal perinatal and developmental history. He came with 1 episode of vomiting and giddiness, followed by weakness of all 4 limbs since 2 days. And this is in December 21. So that time, no history of trauma, no history of headache, altered sensorium. GCS was 15/15. Tone was hypotonia with absent DTRs. So possibility of cerebellar stroke was kept, and initially the first MRI was done in December 21.
21 or 22?
21, sir. I've sent you the video. Yes, sir.
And he had high levels of COVID antibody, and D dimer was very high.
Very high.
So just tell quickly, na?
Yes. So considering strokes, investigations were sent. His CBC, lipid profile, CRP, which were normal. 2D echo was done, which was normal. His COVID spike antigen was positive, which was high, and his D dimer were raised. So it was 3,302. So rest of all the vasculitis workup, ANA, C-ANCA, P-ANCA, which was sent, which was negative. CSF IgG levels, which were also normal, which was 3.84, upper limit being 4. So that time the MRI was done. Yes, sir.
So I have a December 22 MRI.
Okay.
I assume that there was cerebellar injury, because here you can see there is chronic changes in the right cerebellar hemisphere. Is that right?
Yes, sir. So the December 21 MRI, which showed multiple infarcts in the posterior circulation, which and along with that there was a vessel wall enhancement which was seen, sir, and the distal part of the M1 portion of MCA, left MCA, right MCA was also blocked. So subsequently this child was discharged on tablet aspirin, injection enoxaparin, for as the D-dimer was raised, and MCBM was started, and Visolon was started for this child. Gradually, the power improved over a period of 1 month, and so it was Visolon was tapered. Repeat D-dimer, which was normal, so enoxaparin was stopped off, and steroid was stopped in this patient. So repeated MRI was done after 3 months to show the progression, which was normal. In December 22, sir, the child was admitted with complaints of sudden onset giddiness again with fall, and he got a left-sided weakness of upper limb and lower limb. During this time, the GCS was 15/15, cerebellar signs were positive, and left-sided upper limb and lower limb weakness was present, sir. This time also we did a stroke workup for this child, which was completely normal. CSF analysis was done, which was also normal. So this is the MRI of December 22, sir.
Yeah, okay, you have ischemic changes in the thalami, predominantly on the right side. Also the bilateral mesial temporal lobes, left more than the right, the occipital lobes. Subacute or acute ischemic changes in the posterior circulation territory. So cerebellar structures and the brainstem were relatively spared. On the angio, especially the vertebral brachial artery is could not appreciate any stenosis or thrombosis over there. The vertebral arteries of the neck, along the neck, do not demonstrate any abnormalities. So yeah, again you have this.
So in this scan, they had mentioned that there is a right PCA narrowing and left PCA thrombosis.
Okay, that will be possibly visualized on the source images than the MIP, but okay, if they are there, then it's fine.
Okay, sir. Then yeah, so this is the this is not the history, sir. So vasculitis workup was sent, which came out to be negative. Renal Doppler, carotid Doppler, which was done, which was normal. The child was discharged on Visalon and enoxaparin, and we had sent CSF IgG levels in this child, which were raised. So this was 67. So so follow-up scan, which was done after 4 months. So December 22 scan, and after which a follow-up scan was done in 3rd of March 23.
Yeah. The follow-up scan, no acute changes, no new lesions, but the abnormalities in the previous scan demonstrate gliosis and some areas of encephalomalacia. And craniovertebral junction, I could not appreciate any abnormality. To raise a possibility of Bohn syndrome, given the recurrent strokes. Was a CT done by any chance, anytime?
No, sir. CT was not done. The other doubt we had that could it be vasculitis in this child?
Okay, so this is the most recent angio, and there is no beaded appearance, at least on the angiography, no irregularity along the walls. So at least since there's no acute stroke, I wouldn't expect any new abnormalities. Was a vessel wall done anytime during the December 21 and December 22 stroke?
Yeah,
Yes,
it
sir.
showed enhancement, no? Vertebral,
Yes,
some part
yes, sir. It
enhancement,
was.
sometimes PCA.
Yes, sir. It was done. Vessel 1 in imaging was done during December as well as in March, sir. March 23.
But would that explain the recurrent nature, Dr. Kavita? Recurrent.
Yeah, so the question is why we are getting this recurrent, vessel wall enhancement is patchy. It's sometimes coming in V2 segment of vertebral, sometimes coming in PCA. So it is not like it's causing any bleeding or any permanent stenosis. Like a progressive arteriopathy or so is it just recurrent thrombosis, and we are not able to find the cause also. So we are really not sure how to go about this child.
Yeah, we had. I think Dr. Lokesh had mentioned earlier the 9 cases which he had seen with Bohunters. They had recurrent strokes with thrombosis. They can cause dissection also. So possibly I would.
How do we explain the thrombosis? And thrombosis can be explained, but that vessel wall enhancement also will be there in that vertebral and all.
I'm not sure. I haven't seen them. So we need to know the grade of the vessel wall enhancement. Usually when you give contrast, there should be some form of enhancement. But is it causing significant narrowing of those involved structures? That would be inflammation and thrombosis is slightly, again, there are 2 different processes.
And all this has started after that COVID thing. So we really don't know what we are dealing with and how long should we treat with steroids, because once we have treated for 3 months and stopped it and the child has relapsed again. And it took almost 1 month to recover last time. This time also took a long time. So how should we go ahead now, and what other possibilities to be considered? That is the question I wanted to discuss with the panel. So Dani sir or Dr. Eugen, any comments?
No, I've seen a few
And-
patients who develop strokes, multiple, attacks in a short period of time. And all of them have been this COVID positive. And but we have seen some unusual pictures in the sense that there's evidence of arteritis. So there's evidence of occlusions of the vertebral arteries in the neck, in the intracranial carotids, multiple arteries. And I've seen about 4 or 5 cases. And I was wondering what this is because, after about a month or two of this very stormy course, it just dies out. And then you're left with the sequelae. So I'm not sure how, because this patient's, you've shown some occlusion of the PCA. I could not see anything. This is wondering.
Usually don't see it on the MIPS, but yeah, cannot appreciate the PCS.
And that also keeps changing in the subsequent scans. So
Yeah, but
sometimes
this
the
is
right
over a
appears.
period of a year.
Yeah.
So inflammation of that's fine, COVID, but why should you have another stroke after a year? Is it more mechanical related injury or?
Yeah, so that bow hunter thing will review that with the CT and
Yeah.
all, but because all this has started after the COVID and one or the other artery keeps showing narrowing and even a contrast enhancement, which is very unusual for even a bow hunter. Usually they will just have emboli, isn't it?
Yeah.
So any other thoughts? Udani sir, like how long do we treat now? Because last time we gave it for 3 months and I'm really not sure how long to give the steroids. Enoxaparin also we gave for 3 months last time because there was a PCA thrombosis same. This time there is no frank thrombosis, but vessel wall enhancement is still there.
No, vessel wall enhancement can persist, Dr. Kavita, just before.
That's the
Like,
other
not
question I
physical.
had, Nihal.
Yeah.
Is this vessel wall thrombosis always mean vasculitis? Because, Mahendra from Sick Children tells me that it's seen in many conditions and doesn't seem to be very specific for vasculitis. Or for some inflammation, that's what I meant.
Yeah, if you give contrast, it enhances, but the degree of enhancement usually dictates the cause. I would expect some degree of enhancement in the walls, but is it causing significant luminal narrowing? Is it focal? Is it uniformly on both sides? If it's uniformly on both sides, then possibly not causing the.
Because we had this COVID patient who had the this thing, the enhancement continued for 6 months.
Yeah, it's known to continue 6 months normally itself. So the enhancement should not be taken as a grade of active inflammation.
I think it's the blood-brain barrier that get broken down, and interestingly, if you look, we talked about earlier about the IL-6 and some conditions that we see this. They did a lot of study in Aquapoint 4 about the blood-brain barrier and IL-6 when they were trying the medication. And IL-6 is the receptor is very important for the integrity of the blood-brain barrier. And if you think that all of these COVID patients was also like a post-infectious cytokine thing, so that disturbed the blood-brain barrier, then you see this enhancement persisting for a very long time. And that's a blood-brain barrier. It's not active inflammation like we use it in MS to indicate active inflammation. So you can see it. That's just a thought.
Yeah, but the child is also developing symptoms. Is getting strokes.
So I would just evaluate
it's not
for
just
Kavita, just to rule out.
No, but I'm just talking about the enhancement. I mean, I think you look at the stroke, but if you have persistent enhancement of all lesion, you don't look at it as active necessarily.
Yeah.
No, actually, we are not getting persistent. We are getting, irregular enhancement of some part in one scan, the other part in the other scan, like that. So it is not even persistent, and which is really very. We are not able to explain that. So as you said, maybe the blood-brain barrier is not yet repaired, but then it should not happen at different sites every time and show different vessel involvement at different times.
Where would the blood-brain barrier come in a vessel which is, the vessel wall? I'm not sure I understand that. For example, if you have extracranial arteries also sometimes show vessel wall enhancement. Where's that's what I mean. So I don't know exactly this.
Here it will be probably endothelial damage, what we see in post-COVID.
Yeah, I think it's some sort of
rather than
damage which just keeps enhancing for some time.
Yeah. So what would be the guideline to treat such patients? How long do we give steroids? So maybe this time I should give it a little longer and see.
No answer.
Okay, thanks.
No answer because we really don't know. If we knew,
Yeah.
we would have told you. So it's, but I
Sure,
think, you know, your logic of giving a bit more than before makes sense if he relapsed.
Sure. Thank you so much.
Yeah.
Thanks.
Okay, I think we have 3 more, but we'll probably conclude with this one and maybe try to squeeze in the other one. Dr. Vivek, if you're there.
I have to go in
Okay.
5 minutes. Is there any inflammatory case out of those 3 or no?
Yeah, I think the third one will do it for the next meeting.
Okay.
Dr. Vivek, if you're there.
Hello,
Yeah.
can you hear me?
Yeah.
So it's a 2-year-old boy who had come to us a week back. So he had a acute febrile illness, respiratory symptoms for a few days. And then 6 days later, he had right hemiparesis. And the next day he had dystonic posturing of right arm and then bilateral dystonic posturing, more into sort of decerebrate posturing. He was in over the next 24 hours, came to us. He was posturing, encephalopathic. So we ventilated him, but he was well before. And no previous illnesses. And we did a continuous EEG monitoring also because there was suspicion of seizures. His EEG just showed diffuse slowing for the first 24 hours, but over the next 72 hours, it just became flat. And he was treated with IV antibiotics, acyclovir. He had an MRI a day before he came to us, and that's why I wrote the history. There was a history of playing with pups in the neighborhood 2 months back. They were not pets, but father doesn't say there was any scratch. And there's no history of hydrophobia. There's no history to suggest rabies. It's just we were wondering what could be the reason. So this MRI was there when the child came. So yeah, Nihaal.
Yeah, so predominantly left basal ganglia thalamic changes, also the periventricular white matter, subinsular white matter, with corresponding restricted diffusion, also extending down up to the ipsilateral peduncle, subthalamic nuclei over there. Yeah, so predominantly edematous deep brain nuclear structures on the left side, causing some compression of the lateral ventricle. Post contrast, there is some linear enhancement or leptomeningeal enhancement of the structures involved in the left basal ganglia. Angio was done, possibly some bleeding over there, but nothing very significant in the middle cerebral artery on the left side. The left ACA is slightly hypoplastic or abnormal. There is some beaded appearance over there. SWS sequence or GRE did not. There are some punctate foci, but I think there are more vessels than hemorrhage or calcifications. Then I think the next day the child had a CT, if I'm not mistaken, today or 2 days later.
Hello.
Yeah, Dr.
So after that, we did a CSF, showed 80 cells, predominantly polymorphs, and sugar was 30, protein was 80. And because he deteriorated so rapidly, within 48 hours, we did a CT, which showed now involvement of the right side as well. And that EEG got flagged over the next 48, 72 hours. His biofire PCR, CSF, which covers the common bacterial organism, HSV, was negative. We empirically started anti-tubercular treatment, but his evaluation, at least, even though they were polymorphs, but we still did it, was normal. Whatever we could do.
So possibility of rabies and encephalitis is raised. Yeah, they predominantly involve the basal ganglia structures, also the brainstem. And you can see from examples over here, they can also have asymmetrical involvement involving the white matter and the cortical regions. And the other differentials on imaging, at least, which may or may not fit, are the toxic causes, the viral encephalitis disorders, uremic encephalopathy, EPM. Yeah. Autoimmune, I don't think fits clinically in this case. So, Would you still consider rabies and syphilis, Dr. Vivek, or because given the negative CSF biofire? To Rani or yeah.
Yeah, I've seen a case. We actually reported this case many years ago of a child who actually survived for a long time with rabies, in fact, 4 years. And it was proven by PCR and everything else. But what is interesting is, and then you've seen about 6 odd cases who've survived for a longer time, and they usually have changes in the dorsal brainstem as a very early finding, and which then progresses to the basal ganglia, and then it goes all over the place. So I don't know, was the dorsal brainstem involved at all in this case?
Not the dorsal, the ventral is.
Yeah. So.
Peduncle is involved. At least these are the images which. Dr. Vivek, any idea for dorsal brainstem? Doesn't look like it. Yeah.
Sorry?
Midbrain.
The dorsal brainstem, was it involved by any chance? Because yeah, these are the only images that.
No, it was not.
Yeah.
Hello.
Yeah, so for the panelists, if anyone wants to comment, any other possibilities other than rabies to be considered given the rapid deterioration?
Any other differential? So we did CSF rabies, we did send, just got the results today. It was negative, but it was, I'm not sure how sensitive it is.
Did you do the PCR or the antibodies?
So we did the antibodies.
Yeah, so the
Let
antibodies,
me check. Let me check. Sorry, let me check because done from Niman. So do they do? What do they do?
The PCR, the problem is you have to send it within because it's a RNA virus, if I remember
So
right.
this is antibody, rabies virus neutralizing antibody.
Yeah, so that usually you may get a mild titer and then it increases over time. So
Okay.
We didn't give you much time, unfortunately.
Yeah, so it was less than 16. So they did say to repeat it in a few weeks' time. Yeah.
I just had an outside thought. I mean, is it, a peculiar kind of tumefactive demyelination?
So we did as we all do, we gave methylpred. So it didn't help. But is it not that everything is diffusion restricted, whatever the lesion you see? So there's no inflammatory component to it. Not much of inflammatory component. It's more cytotoxic edema, all of it,
yeah.
with some compression as well.
Yeah, but tumefactives in the first scan, that's why I thought it could be that. The second scan obviously is very odd because it happened both sides.
And the contrast as well.
The contrast doesn't again support.
Right. I agree. Yeah. These punctate things are all vessels, huh?
There is some enhancement over there. Some linear enhancement is there, especially over here in these regions. These could be the lenticulosteroid vessels, but possibly here there's some abnormal.
Gauri's got a good point. The nuchal biopsy you can also do, but it shows that I think fluorescence or something. You see the.
So Nimans does mention it. So ideally, we should send skin biopsy, saliva, and CSF.
Yeah.
So family, we did talk to them. The prognosis, they were so adamant that this is not rabies. So we just could convince them to send the CSF sample which we had stored to Nimans. They just didn't agree for the skin biopsy.
Okay, I don't think we have any other comments. Maybe you can get back to us with the antibody after 2 weeks.
Can we stop now?
Yeah, I think you can leave, Dr. Rani. I just do one case. The parent actually requested.
Sure. Yes, go ahead.
Yeah. Ashwin, if you're there quickly, or Dr. Ashmi or Dr. Kamte.
Yeah. So we have a 4-month-old female child who is one of her twins out of IVF conception had presented to an hospital outside in a state of gasping following vomiting with cyanosis and required resuscitation and had to be intubated immediately at admission. Thereafter, the child developed seizures and a first MRI scan was done. This child actually initially, after the child was admitted, a lumbar puncture was done. And that time the child it showed CSF showed 6 lymphocytes with elevated proteins of 376 and glucose of 67. And a point to be mentioned is that at admission, this child required resuscitation during intubation. Thereafter, when the child was taken for MRI a few days later, that time also the child had another episode of cardiac arrest for which chest compressions and adrenaline had to be given. Now, the child was referred to us on day 10 of admission and was still intubated with a poor sensorium. And the CSF report had come by then, which showed low levels of adenovirus in the PCR of the CSF. After the child came to us, there was no spontaneous eye opening and had dystonia with reactive pupils, however, with Doll's eye and corneal reflex being absent. Fundus had shown some retinal hemorrhages, some cotton wool spots, and the baby had come with a high blood pressure documented in the previous hospital and was on antihypertensive infusion, which were going on. And when the baby came to us, when we had on the same night, the baby had another episode of cardiac arrest, for which, however, the baby was revived immediately. And then echo was done, which showed an ejection fraction of 45%, and myocarditis was suspected. Very high NT-proBNP levels were present. Also, some autonomic instability was noticed in the form of heart rate variability and hypertension. We did a blood sample testing for adenovirus, which showed medium levels of the virus present. And patient received IVIG for the myocarditis, after which the ejection fractions improved and the patient was no longer in shock. All vasopressors were able to be omitted. And prolonged intubation was there, therefore tracheostomy was done. Currently, the child is on tracheostomy, but however, we have been able to take off the ventilator. But the pupils are reactive, Doll's eye is present, but the sensorium is still depressed. And but however, there is response to pain and there is limb movements present. So we have 2 MRI scans, one done outside within a few days of admission, and another done about 20 days later.
Okay, so quickly, the first MRI, on top of the diffusion weighted sequences, you can clearly appreciate the cytotoxic injury in the basic frontal regions on both sides. On both sides, the anterior temporal lobe on the right side. But I don't have the ADC sequences to compare the diffusion abnormalities. But overall, the diffusion in the brain itself appears slightly hyperintense, especially the deep brain nuclei structures, the thalami, the caudate nucleus, the central white matter, and also the perimetrial white matter is slightly hyperintense. ADC would have been helpful if these are actually two areas of restricted diffusion. On the flare sequences, again, no parenchymal abnormality standing out there, but you have the subdural, thin subdural collections or hematomas along the posterior cerebral convexities. Better again all along the cerebellar convexities over there. And on the gradient sequences, we have some areas of hemosiderin aligning the subdural collections suggestive of subdural hematomas. And the T1 non-contrast sequences, you have again thin subdural hematomas along the posterior cerebral and cerebellar convexities. Post-contrast, possibly there is some leptomeningeal enhancement along the superficial frontoparietal lobes, predominantly the parietal lobes, but again, the central structures do not demonstrate any abnormal enhancement. Occipital lobes, the temporal lobes, again, I cannot appreciate any enhancement over there. Follow-up MRI 20 days later, child, and this is the scan. Significant progression in comparison to the first MRI, significant atrophy, gliosis, validant degeneration in the cerebral hemispheres on both sides, extracodilatation of the lateral ventricles, subdural corrections on both sides. There are also some parenchymal hematomas in the right frontal lobe with fluid layers. Ischemic changes, sequelae of ischemic changes with cortical thinning, especially in the left posterior cerebral hemisphere. Again, subdural collections, hematomas appreciate on T1 non-contrast sequences, there is some reduction in the volume or hypoplasia of the brainstem and the vermis, primarily the pons over there, and possibly validate degeneration along the brainstem structures. On the flare sequences, non-contrast flare sequences, you have the lamina necrosis predominantly in the posterior cerebral hemispheres, also along the bilateral basal ganglia at the gross parallel structures, subdural collections with some fluid levels along the parietal lobes on both sides. Post the gradient sequences, again, you have these hematomas over there. There was some tortuosity of the vessels, but not significant. Only the convexity vessels demonstrated some areas of tortuosity. Yeah, these are the SWA findings, and spectroscopy was done, which demonstrated elevated choline, and rest of the peaks are reduced. So at this point, the possibilities raised were, given the 3 cardiac arrests and possibility of hypoxic, global hypoxic ischemic injury with the adenovirus infection, whether these changes are contributory to the follow-up scan, given that there is a significant atrophy resulting in bilateral subdural hematomas. The possibility of, I think the initial picture, the child did not have any features of Menkes disease, at least that was not mentioned on the clinical reports, and on the scalp hair and the other skin changes do not demonstrate any changes of Menkes. So the other, unlike, less likely possibility was considered was it a form of abusive head injury, but the child was in hospital for 20 days during this day interval scan. So again, that was a possibility, but we have, at least radiologically, I discussed this with Dr. Mankad himself too, and we thought of is a possibility of sequelae of the multiple hypoxic ischemic injuries resulting in atrophy, resulting in subdural collections, and also some areas of particle necrosis and gliosis. So I'd like to open the case for the panelists. If there's any alternate theory for these progressive changes, the parents got a genetic test done. The genes over here, I think, do not match radiologically, at least, and also clinically, if I'm not mistaken.
I agree, Nihaal. This is most likely the result of prolonged hypoxic perfusion failure, and this is possible within 3 weeks.
Yeah.
So I would not consider really an alternative. And the genetic tests you just show are not related to the clinical situation. One is pontocerebellar hypoplasia, and the other is a gene for dominant dystonia. This is not applicable in this situation.
I think this is a shaken baby syndrome with the first hemorrhage in the subdural areas. You can get hypoxic injury in that too.
Yeah, that possibility is raised, given that there were also retinal hemorrhages, but I think they were attributed to hypertension, if I'm not mistaken.
No, but I mean, those
subdurals are there, they should not be there at 4 months of age.
And no, why should they be there in the first few days of the first? I mean, does it occur in hypoxic ischemic injury like this?
No, is it possibly infective? I mean, this child had adenovirus too. So.
First platelet count and the first thing, was that abnormal when they first presented? Dr. Ashwin?
Yeah, first platelet counts actually in the hospital before were not reduced. No, they were within normal limits. I'll check for the exact values.
There was sepsis also, right, Ashwin, if I'm not mistaken?
You know, I mean, when the patient has like initial presentation, the counts were not very high. Whatever we got in the referral from there, it was told that the platelets were normal, and even total counts were not very low nor too high, and no blood culture had come positive for any bacteria. Only test positive was the CSF, which showed the low levels of adenovirus.
But adenovirus can also cause hemorrhagic cystitis, hemorrhages elsewhere, and all that, right?
Comment of HSV, I don't think it was.
There is, just sorry to interrupt. There is one blood count which is 22,100 in the referring hospital earlier. Platelet count was 4.6 lakhs there.
Okay.
And differential count showed a lymphocyte count of 73% with neutrophils of 20%.
The first subdural, Dr. Nihaal, what would you attribute that to? The first scan, you're saying that there is thin subdural. I was under the impression that the first scan, I haven't seen the first scan, first time I'm seeing it now, was completely all right.
No, there is definitely subdural, but it is the shaken baby ones at least have more considerable or more significant amount of subdural hematomas than what you're seeing here. This is what we commonly see in post delivery related subdural collections, but they should not technically present up till 4 months of age.
Does the first scan show basifrontal hyperintensity suggestive of any viral encephalitis sign?
You mean the parent? I didn't get the question. Sorry.
There were some hyperintensities noticed in the basifrontal region in the first scan.
They are possible. Yeah, we are not debating about that part. Only the subdurals associated around the posterior convexities. That was.
But in terms of hierarchy, this child had a myocarditis. Am I correct?
Yes,
in the context of that myocarditis, she had a need for repetitive resuscitation. And this explains the cerebral atrophy.
Yep.
You don't need another encephalitis.
No, I mean, the question was on the first scan before the. So we're thinking of post infective post cardiac arrest related hypoxic changes resulting in the progression on the scans with the differential of shaken baby. Is that right? But again, terminating a shaken baby would be slightly controversial. Was a skeletal survey done? Ashwin, any idea?
No, skeletal survey was not done. We have had some chest X-rays alone. Yeah.
But no refractive.
There were no fractures noticed on those. The rest of the limbs were not surveyed independently.
At least the radiological differences of other subdurals are, I mean, they're not in glutaric acidureas and all that, but the other imaging pattern doesn't fit into that. So
in the current scan, the subdurals are because of cerebral atrophy. Right?
Yeah, because of the atrophy, it causes injury to the bridging veins, and that causes the subdural correction.
So I think Dr. Mahesh, I don't know if he's there, he was concerned whether these subdural collections need to be drained. If they're because of atrophy, they probably do not, right?
No drainage at all. There is no reason.
There's no reason.
There is no pressure. This is atrophy.
Mm. And the last question, is that in 20 days enough to cause this much of atrophy?
Yeah, I mean, the child had 3 episodes of cardiac. I mean, I think cardiac arrest. Is that right?
Yes, 3 episodes.
Yes, that's right.
So yeah, 3 episodes is I think sufficient enough.
2 required extensive resuscitation. 1 was revived very soon.
Yeah.
Mm. Yes, then we can all agree that the current brain scan changes are secondary to severe hypoxic ischemic encephalopathy because of the severe myocarditis, with ejection fraction of 20%. So that will probably be the first and working diagnosis for this child.
Nihaal, what about that frontoparietal white matter restriction? Can you see any adenovirus infection?
Yeah, Dr. Kambe, that we can see the basifrontal one.
Okay, fine. Yeah.
The only thing I'm concerned is the entire diffusion looks slightly bright. So I did not have an ATC.
Okay, fine.
So if there are also changes of hypoxic injury over there, because it is slightly
Possible.
than normal. Because if you
Possible.
see occipital lobes, the temporal lobes, the cortex over here.
Okay, fine.
You see the signal chain is over here. It's slightly brighter.
Okay.
So I think there's a because there was child had a cardiac arrest during the scan, which I remember the father telling me, and also the underlying infection. So
First arrest was at home. Second happened after the scan. After the scan. Coming back from the scan, as they were coming back to PICU, baby had arrested there after the scan. Actually.
So those are cerebritis changes. I think the basic frontal one.
Okay, thank you.
And these the little hemorrhages, were they multi-layered or any typical pattern, or just are they attributed to hypertension?
Actually, they have reported them as bilateral intraretinal hemorrhages with rod spots and cotton wool spots.
Okay.
And vasculitis, they mentioned.
So cotton wool spots denotes, I think, hypertensive changes. If I'm not mistaken.
Mostly hypertensive.
Okay. All right. So the first possibility, as Dr. Rashmi has mentioned, post-acquired insult causing these changes. I don't think genetic workup is required for that. Is that right, Aidan? Do you agree?
Yes, thank you very much, Dr. Nihaal, for including this at short notice. And I hope this will answer the father's questions as well.
Yeah. All right.
Thank you.
Thank you. We have but I think we are over time, so we'll do that next time. That was Dr. Udani's case, but he has, he says it's okay to do it next time. So, okay, we'll meet again on the 14th of April, and kindly send in your cases by 11th if possible. All right.